Good morning, everyone. At the very outset, I would like to send my sincere apologies for not being able to be live at KATCON venue for presenting this topic on OT and equipment sterilization. Now, why this sterilization is an important subject? This is because it prevents most of the environment-related surgical site infections. Surgical site infections are the second most common cause of hospital-acquired infections. These complications, if it occurs, especially in the deep site of the surgery, it can lead to a mortality of as high as around 77%. Now, the sources of surgical site infections could be both endogenous as well as exogenous. The endogenous is the one which comes from the patient's skin, mucosa, mucous membranes, or the viscera. And it's the exogenous one which includes the infection that is transmitted by the surgical personnel, the surgical room environment, the tools, instruments, and materials brought into the surgical field during surgeries. This is the one which the exogenous ones are the ones which we are most worried about, and the ones which we can prevent. So that's how sterilization would help in preventing the surgical site infections. So we all know the epidemiological triangle. There's an interaction between the agent, host, and the environment. And if this takes place, you get infections. So we are here to prevent the ones from the environment. Now, this concept of having infections has been there since times immemorial. So the awareness about the transmissibility of certain diseases existed even centuries back when practitioners like Hippocrates, Galen, and many other pioneers used water or wine to either clean wounds or instruments before using them on patients undergoing surgery. Even our own Susruga had instructed the operating team members to clean and fumigate the operating theater with vapors of certain disinfectants prior to all surgical procedures. However, it was Dr. Rolf M. Waters who first associated anesthesia equipment as a vector for transmission of nosocomial pathogens. Now, we all know Dr. Rolf M. Waters. He was the one who invented the Waters airway. And this picture is a very famous picture of Dr. Waters with his residents. And if you look at this picture very carefully, you can see here that most of the residents are male, except for one female. This has nothing to do with sterilization, but you can see this lady here. Anyone knows who she is? She's Virginia Apgar, and she was famous for the Apgar score. Now, this picture has another very important significance. You can see this gentleman here. Now, this person is Dr. B.N. Sarkar, and he was the founder member of the Indian Society of Anesthesiologists, and he was the first honorary secretary of the Indian Society of Anesthesiologists in 1947. I just thought I'll just share this picture. Well, coming back to the topic, the problem statement. Now, there is an increasing trend in the Western world towards the use of disposable or single-use equipment to tide over the problem. But for a country like India, to be not feasible. Now, the biggest handicap would be the economic burden on the institutions to keep such a large inventory of disposables, the higher cost to the patients, and the increasing load on the authorities for waste management of these disposable items. We therefore have hardly any choice but to stick to the use of reusable equipment and to perform their proper decontamination and take appropriate infection control precautions as per the standards and guidelines set by the hospital authorities. All of us are aware of the WHO project of safe surgery and saves lives. So this concept was introduced in 2009, and they gave the 10 essential objectives for safe surgery. And if you look at the sixth one, it very clearly states that care must be taken to minimize the formation of surgical site infections by using proper measures like sterilization. And even in the surgical safety checklist, which we use day in and day out in our operating room techniques, and here you can see that in the before skin incision part, if you look at the the nursing team has to answer these questions. Has sterility been confirmed? Are there equipment issues or any other concerns? So even in this surgical safety checklist, sterilization forms a major part. So what are the different levels of sterilization? So this is very important that all of us know the different levels of the effectiveness of decontamination. Now, if you look here, you can see that there is part is cleaning, sanitizing, disinfection, and sterilization. So as we go from below up, the decontamination effectiveness increases. Now we'll just go to one by one. What is the definition of each of this? Cleaning just is the removing of materials that can interfere with the sanitary's effectiveness, but it does not remove any microorganisms. So what does it do? It just removes the dust, dirt, and organic matter from the uh, surfaces. Now, what is disinfection? Disinfection destroys uh, all vegetative pathogens. However, the more resistant ones, like the spores, might not be killed. And so, what is sterilization, which is the highest level? Sterilization destroys not only the vegetative pathogens, but all viable microorganisms, such as their resistive endospores and eggs. But it does not kill the prions. For prions, we require the prion reprocessing. Now, there are certain levels of disinfectants. There is low level, intermediate level, and the high level ones. So we'll just see what the low level ones are. The low level ones are the alcohols, and the intermediate ones are the iodophores, and the high level ones are the aldehydes, that is the glutaraldehyde, Sidex, and all that you use. So there are the different levels of disinfectants and where they should be used. That depends on the medical device that is being used. So there is a classification that is called the Spalding classification. So the Spalding classification, it divides these medical devices into three groups. That is critical, semi-critical, and non-critical. Critical means these devices enters the sterile tissue or the vascular system, like the scissors, scalpels, or your Seldinger needle for putting a center line. The semi-critical ones are those which contact with intact mucous membranes or non-intact skin, like your laryngoscope blades, the endoscopes, or the TE probes, your bronchoscope. All that comes under semi-critical devices. The non-critical ones are which contact with the intact skin, like your blood pressure cuff, the stethoscopes, and the linen that you use on the patient. So depending on whether the thing is critical, semi-critical, or non-critical, the sterilization differs. So critical objects, it should be sterile. Semi-critical ones should have a high-level disinfectant that is used on them. And for the non-critical ones, you can go in for an intermediate level or a lower-level disinfection. Now, Spalding classification was modified later to include environmental surfaces. Now, this category was specifically added to include items or surfaces which are likely to harbor organisms transferred by those working in the OT environs. It includes surfaces of medical equipments, laryngoscope handles, infusion pumps, equipment cards, anesthesia cards, monitor knobs, and blood warmers, monitoring cables, and other equipments which are not the direct patient contact. So here we require an intermediate or a low level disinfection. Now, the same equipment can become uh, different. It can become critical, non-critical, or semi-critical based on where it is used. For example, your ultrasound probe. Now, all of you would be using the ultrasound probe in the theater. Suppose for just scanning a patient, you just do a scout scan and it's done on the intact skin. You just require a low level or an intermediate level of disinfection. But suppose the same ultrasound probe, which is like a TE probe, is being inserted. The TE probe has to have a high level because it is contacting with the mucous membrane of the esophagus. Now, suppose you are using the same ultrasound probe to put in a central line or giving a nerve block. It's ideal that it should have it should be a sterile or a high level disinfectant should have been used. Like nowadays we use ioban on the ultrasound probe, so it becomes a critical object. So the same probe becomes a non-critical, semi-critical, and critical depending on the situation in which it is used. So what are the different steps? The first step for decontamination is cleaning. This is followed by other sterilization, disinfection, and then the equipment can be used or can be stored as per the requirements. Now, cleaning is a very important step because it helps in removing the it helps in reducing the bioburden. So what you do is you can soak the instruments in sodium hydroxide or in an enzymatic solution. Now the enzymatic solution is a really good because it helps in removing the not visible uh, coagulum that can be formed on these instruments, and followed by either a manual cleaning or a automated cleaning. So the manual cleaning can be done by using brushes and high pressure water hoses, or you can use an ultrasonic cleaner, which sends ultrasound waves and agitates the water in the system. Now, those involved in cleaning should take their own precautions to protect themselves from infection. So, whenever feasible, complete protective clothes consisting of headgear, eyewear, mask, fluid, repellent gown, and protective footwear should be worn. Now, thorough drying of these clean items is a must because humidity encourages the growth of certain organisms. Now, for example, if so the instrument has some liquid or water on it, and you're going in for a liquid sterilization. So what happens? There is dilution of the liquid sterilizing agent that you're adding. Suppose you're going for gas sterilization, and for example, you're using ethylene oxide, ETO. So what happens? ETO will dissolve in the water on the instrument and forms a very toxic ethylene glycol, which is very difficult to remove. So, and it's going to go into the patient and cause problems. So be very careful. You make sure that the cleaned items should be towel dried or air dried. And if possible, you can put them in the air drying cabinets or even use the hot air oven. So the processing pathway is once the instruments are used, it can be held in a pre-cleaning area. Then you rinse it and clean it either in an ultrasonic machine or in a automated washer, and then package, sterilize, and keep it for storage. Now there are different techniques of sterilization. You can go in for a mechanical method, physical method, and chemical method. Here we will be discussing on the physical and the chemical methods. The physical methods are basically heat. So heat can be further classified into moist heat and dry heat. The second one is radiation. And in chemical, we have different chemicals that you're all familiar with. We'll go into one each of them. So first of all, we'll go into dry heat. So dry heat, the one is hot air oven. And what is this used for? Basically, this is used for sterilizing the laboratory instruments. So here, this is a picture of a hot air oven, and this is the working from bottom. Air gets heated and then goes all around the hot air oven. There are different types of hot air oven. This is the conventional one or the gravity one. Here you can see that there is a heating coil and air gets heated, and once the air is heated, it becomes lighter and then it travels up along the hot air oven. This is a convective hot air oven where there is a fan kept for a normal distribution of air. This is a side draught uh, hot air oven where you can see that there is a movement of air. Again, here there's a circulation fan. Movement of air is from left to right, and it passes through a HEPA filter. So you have more sterilized air going through the hot air oven. The next phenomenon which is being used, or physical method that is being used, is the moist heat. So moist heat, again, there are three different levels based on the temperature. So below 100 degrees it is called pasteurization. It is no more considered as a sterilization method. It's a high level disinfection method. At 100 degrees centigrade, you have boiling and steam sterilization. Above 100 degree, we have autoclaving. So autoclaving is nothing but steam used under high pressure. And this is a schematic diagram of how an autoclave looks like. I'll be showing you an animation on this. This is a horizontal autoclave. Sorry, this is a vertical autoclave where this you can see it is standing upright, and you put in your equipment to be sterilized in this, and it sterilizes. This is a horizontal autoclave, and you can put in your instruments and sterilize. This is a small video on the working of the autoclave. This is an animated one, and you can see that the autoclave has different parts. And so if you look very carefully, there's a steam jacket which goes all around the steam chamber. It is a steam chamber in which you put your equipments that have to be sterilized. So the door gets opened, and this is your uh, chamber, where steam chamber, where you put in the equipment that has to be sterilized. Close the door, and you can see here that this is steam release supply valve. The steam will now come all around the steam jacket. You can see the steam coming around all over the this is all around the jacket, steam jacket. And later, this steam jacket valve then gets opened, and through this tube, it then goes into the steam chamber. So initially, a vacuum is applied to remove the atmosphere from the chamber, and then later the steam is the steam supply valve is shut off when pressure inside the main steam chamber becomes appropriate. So the temperature and the pressure must be maintained during this period in order to properly autoclave. And at the end of the time duration, then what happens? You get into the cool down phase. So the cool down phase, the this exhaust valve is slowly opened and the steam is removed. So this is how the autoclave works, and this is all now automated. And if the temperature is increased, you can reduce the time for the autoclaving. Okay, so this was just an animation. So what is the difference between the moist heat and the dry heat? So moist heat is the autoclave one, and dry heat is the hot air oven. So moist heat, we have water and steam, whereas in dry heat there is no water and steam business. It is just flame and incineration. So the technique is, it is based on protein denaturation and coagulation in moist heat, whereas just protein denaturation in dry heat. And another important thing is the process in moist heat is under pressure. So suppose for 121 degrees, if you heat the steam is at 121 degrees, so what happens is you will have to sterilize for around uh, 15 to 20 minutes. Whereas if you increase the temperature to 136 degrees, you can get the sterilization effect in 5 minutes. So this process takes less time, that is the moist heat, while the dry heat takes more time. Okay. So we now move on to the next sterilization technique, or the chemical sterilization, which could be gaseous sterilization or liquid sterilization. And we are all familiar with this thing, that is Sidex. All of us are using it. What you see here is the activator. So this Sidex, I think all of you have seen it. It is just a plain colorless liquid. But once you add this activator, what happens is it becomes a green color solution. And you have to use, for high level disinfection, you have to use this, you have to put your instruments or your scopes inside X for around 30 minutes. But if you require sterilization, it has to be kept for almost 10 hours. So you need a 1.5% solution. Once you put this activator, you have to finish off this solution in 14 days. This is not a very safe solution because it gives vapors, and it can cause asthma-like symptoms. It can cause eye irritation. So you should be very careful of using the protective things. And when you dispose of this liquid, you should add a neutralizer like glycine or sodium bisulfite, so that the vapors don't injure you. So to overcome all these problems, there is something called Sidex OPA that has come into the market. And here you don't require an activate, and it is less harmful. It does not vaporize, and it does not cause injuries, and it does not require a neutralizing agent when you have to dispose it off. But however, it is very costly when compared to your normal glutaraldehyde. So this is what orthophthaldehyde. Okay, so the Sidex OPA is orthophthaldehyde. The other agent is peracetic acid. Now, peracetic acid has no decomposing. That is the end products of the sterilization are not dangerous, and it can either be used in an automated chamber where you add I'm sorry, so you add 35% peracetic acid, and automatically it sterilizes the uh, instruments. Now, another way of doing it is by having a mixture of 1% hydrogen peroxide and acetic acid, and then it really gives you peracetic acid, and this mixture you can keep it for again 14 days. The other classical technique is the ETO, which all of us are using. And we have this huge ETO chambers, and there is an ETO tank which floods the ETO chamber, and where the load is, it gets sterilized. Now, ETO is a poisonous gas, so we should use all precautions when you use ETO. And it's an odorless and poisonous gas, and the deactivation of microorganisms depends on the uh, ethylene oxide concentration, the relative humidity, the dwell time, and the temperature. This is just the schematic representation of ETO machine. So what it does is initially it draws in a vacuum, and then you add steam to increase the temperature, and then you have a conditioning period. At the end of the conditioning period, you the ETO cartridge opens up, and ETO is added into the system, and then you have a well period. So this is the period when sterilization takes place, and so almost this takes place within the first 3 to 4 hours, and then you have the post well evacuation. And so what it does here is there is gas washes that are given, air is given in and evacuated. So this is done repeatedly over the next 6 to 8 hours, and then it is ventilated outside. And this gas is that is being is sent out is poisonous. So it should be sent out high above the building. Okay, and then you can release the vacuum chamber, and the materials after being ETO can be removed. But now there is some advancements like the flexible chamber, where you have different size bags, and what happens is you can put in the instruments, and then whatever you can put a very small amount of 5 to 18 grams of ETO in as a cartridge inside, and vacuum is applied, and you initiate the ETO sterilization. And there you can put in a purge probe also, which can evacuate the ETO at the end of the cycle. So the advantages are the doesn't require such a big space, and the ETO used is very minimal, and almost all objects can be sterilized with ETO except for the liquids. Liquids cannot be sterilized with ETO. The next one is plasma sterilization. Now, plasma is referred to as the fourth state of matter, and you can use this for sterilizing your costly probes. So what is done exactly here is hydrogen peroxide as liquid is heated to form hydrogen peroxide gas, and then when it is subjected to an electric current, it gets transformed into the plasma. So plasma is the fourth state of matter, other than gas, liquid, and solids. So what it does here is plasma has a lot of reactive species and reactive oxygen species. So what it does is denatures the proteins, damages the nucleic acids, breaks down the cell walls and cell membranes, and causes death of the microorganisms. The other technique that we can employ is radiation. Now, radiation could be ionizing radiation or non-ionizing radiation. Ionizing radiation are the gamma rays, and the non-ionizing ones are UV radiation. So a radioactive isotope like cobalt 60 gives rise to the gamma rays, and this is the most popular one. The other one is using an electron beam accelerator, which can give either an E-beam or an X-ray. And the advantage is there are in the electron beam accelerators, there are no waste products, and it is very effective form of sterilization. Well, the problem with this is it can cause, you need specialized equipments, and it can cause radiation. So we should be very careful. Have all radiation protection should be taken, and you should have also a dosimeter. And what it does is this ionizing radiation can cause direct cell damage, can cause by damaging the membrane, as well as directly it can cause DNA damage, or it can cause the formation of reactive oxygen species and cause damage to the DNA. Ultimately, what it does is kills the microorganisms. Now, coming to the non-ionizing radiation, you are all familiar with UV light, especially after the advent of the COVID pandemic. So, which part of UV light is germicidal? It is the UVC, UVC and the far UVC, which are germicidal. And what it does again, it causes modification of DNA structure and inactivation, stops the cell growth and causes sterilization. So you must have all seen this. These UV lights were brought into the OTs as well as into the OPD and and sterilizing these areas. And this is a chamber where UV light is sent and you can sterilize your equipment. Most of our operation theaters are now equipped with UV light. The other newer one technique is the ozone. Ozone chambers are now available and it is FDA approved. So what it does is air or oxygen is sent through electrical current and ozone is formed. Ozone, oxygen molecule is first exposed to electric high voltage and the oxygen molecule splits into two atoms. The oxygen atom then connects to the oxygen molecule and forms ozone. And what does ozone do? Ozone quickly attacks and eliminates contaminants like bacteria, viruses, comes into contact with. And what is the end product? It's just pure oxygen and air that remains. Now, how do you monitor this is efficacious? Now, you can have physical monitoring. Suppose in an autoclave, you can look whether the temperature has reached, whether the pressures have come up. So that is on the dials. You can use chemical monitoring. You can use biological monitoring. Now, chemical monitoring is the form of strips. Type 1 to type 6 strips. Type 1 is kept on the outside of the package, whereas type 3, 4, 5, and 6 are put inside the package. And you look at the color change as mentioned on the strip. The other one is using the spores, can either be spore strips or spore vacuums, where specific bacteria for for testing the efficacy of specific sterilization methods. For example, for steam, people use Bacillus sterophilus. So that just takes longer time because it has to be incubated to know whether the organism is growing. So it takes, now you have fast incubation, you can get results within almost an hour, whereas previously it used to take 2 days. Now coming to individual item concentrations, now anesthesia machine and equipment are potential vectors for transmission of nosocomial infection via the anesthesia person's hand. So we should make sure that before the next case, the items that are kept should always be on clean surfaces. Now, the patient's respiratory system is in direct communication with the machine via breathing circuit. These are very long, corrugated, and difficult to clean. And if you are going to ETO sterilize them, make sure that there is no water particles. So it should be air dried. It should be air dried before you ETO them. And it should be reused only if you have used the YPs. You should have used a filter at the you can see a bacterioviral filter at the uh, expiratory end. So that should be, and this filter should be changed. Now, face mask, it is being reused. We all know the reusable face mask. It should be soaked in water and detergent, cleaned thoroughly, rinsed, dried, and then subject to sterilization or high-level disinfection, taking care not to damage the pneumatic cushion. So, one face mask, if you use on a patient, the next case you should not use the same one. Wash them thoroughly and so use a high-level disinfection. Coming to supraglottic airways, now they are used for design for repeated use and should be rinsed after removal, soaked in enzymatic detergent, and then autoclaved. So these should be sterilized and like it has been mentioned on that for how many times you can use it. So maximum of 40 times. Reusable gum elastic, which is again you're introducing it with the trachea, so you should have a high level of disinfection or sterilization can be ETO sterilized. Now, what about your laryngoscope blades? Now, laryngoscope blades are the ones which we are not very careful, and it so there is some residual contaminants around the light sources, especially these areas should be cleaned thoroughly with enzymatic detergent. So that it's difficult to see areas. So that should be very should be cleaned very well using enzymatic detergent. There are numerous studies where you can see the laryngoscope handles also you should be very careful, especially these knurled types. They get contaminated and it's overlooked by most of us. They should be washed, disinfected, and should have at least a high level disinfection. And while using them, probably when intubation, all anesthesiologists should have gloves, should use gloves. Now, coming to a few words on sterilization of OT, all of us know that the different levels. There is a protective zone or the level one, the clean zone or level two, which includes the recovery, the pre and post anesthesia area, and the aseptic zone, which is the heart of the operating room, that is the level three, and the disposal zone is level four. So all of us should maintain this zoning in our operating room. And a few words on the AHU, that is the air handling unit. It consists of basically three parts. The first part is where air is taken inside, and there's a small filter there where air is taken, and here it gets mixed with the recirculating air. And from here it goes through a 5 micron filter into the next chamber where there is a condenser where the air is cooled, and then using a fan it is passed through a third filter, that is 3 micron filter, and then it passes through thermo-insulated aluminum tubes into the HEPA filter, which is a 0.3 micron filter. And after that, it forms laminar airflow. Now, very important that we have at least minimum of 20 to 24 air changes in the theater. The temperature and humidity should be maintained, and leak test and the air velocity test should be tested to test the integrity of the HEPA filter. So you should do it at least once in 2 to 3 years, depending on the usage of the theater. And the leak allowed is 0.01%. It is done using the polyalpha olefin test. Now, cleaning the operating room, it should be done to prevent the patient, to minimize both the patients as well as the healthcare workers' exposure to potentially infectious microorganisms. It should happen between patients. It should happen every day before surgery begins, and at the last operation of the day, which is known as terminal cleaning. And deeper cleans can be carried out once in a week. So you should always use wet mops. Don't use dry brooms, because when you use dry brooms, you are going to just spread dust in the atmosphere. And nowadays it is suggested to use a 3-bucket system, where the first you mop the floor using a detergent and water solution in bucket 1 to get rid of any dirt or grime. The second, you mop the floor using the plain water, that is to remove the soap residue. And third, once the floor is dry, you mop it using disinfectant solution. For example, you can use 1% sodium hypochlorite or bacillocid. And again, when you wipe the overheads or the walls, always use moist mops. Don't use dry mops, even on the equipments. And use a high-level disinfectant solution. Now, how do you know whether your OT is sterile? You can use settle plates, you can use the contact plates, or you can sample the air. And there are certain, for environment monitoring, WHO has given certain standards. Now, fumigation. Now, this is a very controversial one. The CDC USA does not recommend routine fumigation or fogging of OR with any available disinfectants. Now, fumigation is only recommended if the patient that you have taken up in the theater has any airborne infection like open tuberculosis, chickenpox with florid lesions, or the COVID virus. Now, these release aerosols into the OR atmosphere. Now, fumigation should be done only after thorough terminal cleaning. And the recommended disinfectant is super hydrogen peroxide with silver ions, and the contact period of 45 to 60 minutes. And once you enter into the theater, you can have a chilly sensation in your eyes. Now, summarizing, anesthesia personnel who are involved in the care of patients who harbor potentially pathogenic organisms. So, in anesthesia settings, which requires expeditious performance of multiple and complex tasks and procedures, hand hygiene, decontamination, and sterilization routine is often overlooked, despite having adequate knowledge. Therefore, there is a need to have national guidelines for disinfection and sterilization of equipment in operating room environment as well as in the ICUs. So then these recommendations should be strictly adhered to. Thank you for your kind listening. Thank you once again, and kindly accept my apologies.